Now I would like to ask the first speaker, Professor Massimiliano Sorbello, who will talk about the use of video laryngeal mask in clinical practice. Dear Max, the floor is yours.
Thank you, Thomas. It's always a pleasure to be together, even virtually, also with my very good friend Pavel. And thank you for UE Medical for this opportunity, because I always believe that sharing knowledge and diffusing this information is really, really important and useful towards a better and safer airway management. I guess you should see my screen. So here I am. I'm going to talk about the use of video laryngeal masks in clinical practice. I'm really found with airway management, as you know. So this is actually my conflict of interest, many of them, but no one will affect my talk today. And this is where I live in. This is Sicily. It's a beautiful island, a lot of sea around. And actually, this is where I work, which is down in the south in Ragusa Hospital, where I teach, which is Enna in the middle of Sicily, and where I live, which is Catania on the east coast. Maybe the being so close to the sea also helped with my love for supraglottic devices, because as you can see here is a picture for many years ago. I was always taking a supraglottic also in my diving. Anyway, the point is that I've been really fond with these devices, even because I had the chance and the luck to meet important people such as Cendi Verghese, Archie Brain, and to become very good friend with them, and also to find all around the world great experts such as Thomas, Pavel, and many more. I decided to get to the point of the visual laryngeal mask, just in a parallel with Charles Darwin, Origin of Species. So we're going to make something like the origin of supraglottic devices by means of natural selection. And we cannot but start from the very first one, which is the idea of a young Archie Brain to combine a Goldman dental nasal mask with an orange tube. And he came out with the very first prototype of the laryngeal mask. This prototype can be found also in a painting by Velasquez in 1630, as you can find here, but it is obviously a joke. The very first paper was dating in 1983, came out on the British Journal of Anesthesia, introducing this new concept in airway management, because it was basically a new concept coming out. There were a lot of uses. This is the diary from Archie when he's describing his first rescue use. You can find down there a young Archie Brain using the very first prototypes, and since then, a long, long way has been done with supraglottic. A few years later, in 1987, Michael Fruss developed another concept, which was the combi tube, which was a direct evolution of the concept of the esophageal obturator. So not anymore a cuff embracing the larynx, but a couple of balloons isolating a closed area to access the airway. Both products had their impact, so that in 1993, the very first ASA guideline for practice management of the difficult airway included both of these devices in the airway cart as rescue devices in case of failed intubation and ventilation. This was the original use, and this was basically the most important function of these devices for many years going on. And we may say that's all, we could stop here, because many years after their introduction, these devices are still largely used. But the world goes on, so as time passed by, there was more and more room for supraglottic devices. They always started with a rescue function, and they were used in OR, in hospital, in emergency department, out of hospital, also in the military, and there was also studies describing their role in space medicine. This meant that their use was more common and common, their knowledge was more common and common, and this made also a strong impression on the market, so that many companies start to produce their own supraglottic devices. I spent some good time publishing this paper, which is a kind of evolution of supraglottic devices in a Darwin perspective. So you see that from the originally laryngeal mask and combi tube, many devices came out with new and interesting features, first generation, second generation, different materials, different options, and different advantages and disadvantages. This is interesting because it mostly reflects two big families. So the LMA species, which are designed with a cuff to embrace the larynx, they can have different features, different performance. Some of them, they were born allowing intubation, and particularly the fast track, which I want you to remember because this was the first device was designed for a rescue intubation through a supraglottic with some specific features like the epiglottis elevation bar and whatever that made him a very successful device. On the other hand, we had the combi-tube species, which for their nature were less keen to intubate. So you could use these devices, but intubation through these devices was not possible or, just in rare cases, extremely difficult. The continuous use of this device made them work from rescue to routine use. So what happened in those years is that a lot of people started using these devices not only as a rescue for difficult hours, but also as elective devices for elective procedures, given a certain number of theoretical and real advantages that may derive from these devices. In this perspective, using them every day, we learn that there are some absolute contraindications for the use. So if our patient does not open the mouth, like you see here, or if there is some glottic or subglottic pathology or stenosis or edema, these devices are not performing good. This is obvious because they don't pass the vocal cords. So if you have any obstacle or restriction there, they cannot work properly. In the beginning, there was also a certain reluctance in the use, at least for the what we call today the first generation, whenever you had obese patients, high intra-abdominal pressure, including laparoscopy, pregnancy, and full stomach. And this made some sense because the protective effect depended on the cuff leak pressure. And if these devices were not performing so good, there was a serious risk for aspiration. These limits were, in certain sense, reducing their use or limiting their use until when something changed. This is an old picture of me. This was 2004. It was some conference. I was there with Archie Brain, and he was just discussing the concept of the second seal. This was the time when the LMA Pro Seal just came out. So this was an evolution of the classical laryngeal mask, where a new design of the cuff, but above all, the creation of a gastric access made a big change in the world of supraglottic devices. It introduced the concept of the so-called second generation, and the presence of a gastric access was really a revolution because it allowed some position tests, like the drain tube leak test, but above all, it created a direct venting opportunity for intra-abdominal pressure. So you needed less cuff pressure to get more seal. And this made a big difference because this opened towards the use of the advanced use of supraglottic devices. In this perspective, the intuition from Archie Brain was also perceived by other products. So there was a series of second generation devices which allowed more or less position control, gastric emptying, and increased sealing. They were used for emergency, but also for routine. And in certain sense, some people start to think of these devices as a real alternative for tracheal intubation. This was also clearly demonstrated by the NAP4, the large audit which was conducted in the UK in 2011, where, interestingly, the lowest number of aspiration cases occurred when a supraglottic generation, where a supraglottic device was used. Obviously, you were using the tube in emergency, you were using mostly the LMA electively, but what was important that the lower number of aspiration occurred with LMAs, and particularly when a second generation was used. This was the first step towards advanced uses, it was quite common to find out more and more people, including myself, using the supraglottic for laparoscopic procedures. It was used in obese patients, in prone positions, and in more and more advanced settings where the classic laryngeal mask had failed or was not at all to be used. And this is why I was always happy with Archie, and I always trust him because there was an impressive background in terms of research behind all this evolution of supraglottic highway devices. Some interesting devices came out all along the time, and let me say they had specific features. So more chambers, they could have different performances, and interestingly, it was the time for the C track, which was an evolution of the fast track, with the original intent to get a vocal cord visualization during ventilation or intubation. But interestingly, if you look at these devices, all of them, they are not anymore produced. So the fast track had a great success, greater success if compared with the C track, which is not anymore produced long time today. But it was time also for a third generation, or they say maybe not a third generation, but a further evolution of the second generation, newer devices, better intubation performance, and once again, the idea of having the opportunity to visualize vocal cords and larynx inlet during ventilation, during intubation. You see a couple of them in these slides, but we'll try to go through this concept in the next slides. So the idea behind all of that was probably the Loch Ness effect that the seeing is believing. So when we use a laryngoscope, we look at the vocal cords, we see the tube passing the vocal cords. When we use a supraglottic, we don't have this option, or at least we did not have this option. Evolution of these devices allowed the incorporation of optic inside the cuff or close to the cuff so that we could actually take a look at what was happening in the larynx. So the movement or the idea to switch from the fast track to the C track was basically the idea of having a look at what happened during our ventilation and intubation attempts. This is one of the first paper about the C track, and it contains everything. So it was very successful for ventilation. It allowed intubation, but the view of the larynx was not always so good, especially if compared with laryngoscopy. And the authors clearly state here that expectation must be moderated. And this is why probably the C track didn't have a big success. Actually, I like to use this Chinese proverb, the eyes are useless when the mind is blind. Or at least I was told it's a Chinese, but it looks like that from the wiseness inside. Because, I did it on myself. I tried the C track many times. And actually, most of people were expecting that you put the C track in and you had immediately a perfect view of the larynx. This is something you could achieve only with some maneuvering, knowing anatomy, knowing the device. So it is not a magic wand. You need to work on it to make it work in the best way. But probably the biggest misfortune of the C track was comparing it with the video laryngoscope revolution. In those years, the very first video laryngoscopes started to come out, and the idea was always the same. Video laryngoscopy allowed a better vision, it allowed intubation, and probably this made people abandon the idea of a visual laryngeal mask. So video laryngoscope, we know today, they are the best devices performing for intubation. This is the recent meta-analysis from last year, a couple of years ago now, from the group of Tim Cook, and there's no doubt that these are the devices to maximize first pass success. Nevertheless, we need to remember that no video laryngoscope can provide oxygenation, and people die because of mixed oxygenation, not because of missed intubation. This is why probably there was a renewed attention towards supraglottic devices because they can always allow ventilation and oxygenation, and the new interest in having visualization with supraglottic devices. With this spirit, there was the total track, an idea from my friend Pedro Acha, it was a combination of a supraglottic device, of a video laryngoscope, including opportunities for suction, gastric emptying, use of bougies, and whatever. This was the first paper from a Spanish group and a preliminary evaluation of 300 patients, and the initial results were quite promising. So they said it works and it appears effective for our management. I like to cite also my friend Thomas Gaziski from this paper. They were comparing it with the Macintosh and the TrueView, and results are interesting because obviously you can get better ventilation, you can have a better view of the larynx because you can get all the time you need to achieve the perfect view because you are thoroughly ventilating the patient. So the conclusion once again was encouraging the need for more studies and to see whether this device could have applications. But for those who use this device, I was between them, the idea was a little bit different because it was really bulky and actually it was a little bit complicated because sometimes you need a lot of adjusting maneuvers, sometimes you get confusion with all the holes and available channels. So we used to joke on that if you want to use this device properly, you really need a bachelor in civil engineering because it was complicated. And this is the reason why probably also the idea of the total track was not working. And I don't know if it's officially out of market, but for sure is not so used anymore. What is strange is that if you look at literature, there is a clear evidence for having such devices. So the advantage of a supraglottic, which is delivering oxygen, and the advantage of a camera, which is correcting malpositioning and have a visualized intubation. So in this perspective, we need to take a look also at this last device which came out, so our Seco VLM. And this is interesting because this device was born with the idea of going through some of the previous limitations. So very interestingly, it's a second generation devices with a highly performing silicone cuff. It comes with a gastric access, which can make it work properly as a second generation devices. And it comes also with the opportunity for intubation and a further channel where you can allocate a visual stylet. So you can have a visualization of what's happening inside the laryngeal mask. You can have it with a stylet which is not integral part of the device so that you can reuse it for future use. So you also can save money in this perspective because you just have a disposable mask and a reusable stylet. This approach seems interesting, seems promising, because it puts together all the potential advantages of these devices, because you can have a visualized insertion, you can correct malpositioning by directly looking at what's happening. This way, you can have a better gas exchange, you can reduce the potential for damage to the airway, you can get a better oropharyngeal leak pressure, you may also record your procedure, but above all, you can have an oxygenated intubation through the supraglottic device without use or without the need of using an extra bronchoscope, because this was possible through many second generation devices, but you needed to add an extra bronchoscope inside the tube just to check that everything was going in the right direction. Like this, you have everything in a single device. This is one of the first studies about the Secobel VLM. And what you see here, they had also a scale for graduating the laryngeal view. You will notice since now that the laryngeal view is always lateral because the stylet is placed on the right of the cuff. So you always look at the larynx from the right side. Interestingly, you can have a better vision just adjusting the position of the devices. So in the second attempt, let me say, or in the second view after adjusting maneuvers, the results were very encouraging. And through all of this, the oropharyngeal leak pressure was really high with 32 or 36 centimeters of water, which is definitely a high value, allowing a protection from aspiration and isolation of the airway. This is another paper about the same device. Once again, grading of the laryngeal view, a comparison with bronchoscope, and once again, the demonstration that having an adjustment which is driven by the visualization of the larynx can improve the sealing, the performance, and the same view. And interestingly, from this paper, you see that insertions adjustment were performed once in the majority of cases, so just one adjustment makes it work. Ventilation was satisfactory in almost all cases. Sealing pressure was really high with 34 average, and were really few cases of postoperative sore throat and hoarseness. So a device which is working and which is also enough safe if you want to push its limits. So the conclusion was happy about this device, and they say that it could be a promising device for our management during general anesthesia. This is one of the videos that Thomas provided me, so thanks Thomas for this. You can see here how the patient is on a collar, and being on a collar means that you may have some restriction for use of these devices. You see, in fact, the limited mouth opening can call for a little bit more force for introducing this device. And what you see here is that you can make it work quite properly, because at a certain point, I'm sorry because of the video is not working so good, but you see here that you may get interesting performance in terms of ventilation, and you will see that at a certain point we can see all the time on the camera here on the left of your screen the visualization of vocal cords, and you can perform intubation through the devices. So you are actually ventilating through the device, and you can perform intubation when you need to go into a major or a higher level of control of the airway of the patient. This is another study with use of this device in comparison with the Supreme in a lateral laparoscopic urological surgery. You can see that oropharyngeal leak pressure, the peak airway pressure, and the difference between two devices is literally nothing. So it's as effective as let me say, a more tested device such as the Supreme. And what you can see here is that using the new device, the Seco VLM, you had a greater oropharyngeal leak pressure if compared with Supreme, and the first attempt success rate at alignment of the mask was higher, because obviously you can check directly on the screen what's going on, and so have tailored adjusting maneuvers. This study was recording longer insertion time, which is obviously because it takes more time to adjust it. But I'm rather much happier in spending more time in proper positioning than rather having a shorter time, but without knowing my exact position. And the major presence of blood staining in this study is obviously corresponding to a different thickness and shape of the mask. Nevertheless, it was really few cases and not conditioning clinical outcomes. This is another video which comes from Thomas. You'll see here lateral position. The device can be quite easily inserted, keeping the vision all the time. So you can have a continuous check on the screen what's going on, and you can adjust the position of the device in real time. Because whenever you're not satisfied with a good sealing of the laryngeal inlet, you can always work on the cuff pressure, you can inflate, deflate, reposition, move, and always with the opportunity to ventilate your patient through all the procedure. So this is a really great advantage because you can always know where you are while keeping your patient constantly oxygenated. This is interesting because it's actually one of the potential applications also in prone position, which was described also by Thomas here. And this may have also benefits in obese patients where, we have a limited functional residual capacity, where the saturation occurs faster. So this device could be used as an intubation conduit. So just to avoid the saturation, you can do it under visual control. And if you want, you can also keep the device in place, maybe deflating the cuff and having it also as an exit strategy. So when surgery finishes, you can take your time, extubate the patient with all the rules for extubation, but keeping the Seco VLM in place so that the patient can be fully awake on this device with a stenting effect on the airway. So that would benefit a lot. It would be a kind of modified Bailey's maneuver, allowing the patient a full recovery when the full muscular tone has been achieved. This is also another paper about the use of this device in pediatric patients. Interesting here, it was compared with the EMBO Aura Eye, seeing that device insertion time were comparable, that the oropharyngeal lip pressure was absolutely comparable, maybe a little bit higher for the Seco VLM. Intubation time was similar, but the advantage of seeing what's going on, and also extubation time was comparable. So also in this setting with pediatric patients, there were really encouraging and good results for this device. This is another paper where they are comparing the Seco VLM with the iGel for flexible bronchoscopy guided intubation. And it's very interesting because if you use Seco VLM, time for intubation is less than 20 seconds. If you use the iGel plus an extra bronchoscope, it takes something like 50 seconds. So it's quite obvious and intuitive that if you have a video system embedded in the mask, you can get a better performance in terms of time for intubation. Does it make a difference? Well, it could, because during this time window, your patient may desaturate, calling for you to interrupt the procedure and ventilate again. So if we have an option to be faster, that would be protecting in terms of risk of desaturation. So also in this case, and the authors underline it, the device allows continuous oxygen supply during intubation, which is obviously a big benefit. We've been using this device recently, thanks to the UE Medical and the Italian branch, and they provided some samples because we have plans to develop a multicentric study, and we were just discussing with Pavel and Thomas, we may include also international centers. The idea is to assess the performance of this device with a visual opportunity in, and the idea is evaluating what is going on with the visual, so how good the vision we can obtain, the oropharyngeal leak pressures and all ventilation parameters that can be assessed. And this should be the baseline, because what we want to test and demonstrate is the reliability of this device as a first choice for elective procedures where you can always adjust your ventilation and positioning. Probably we will going to limit the intubation performance to the rescue use, because it will be complicated from the ethical point of view. But the plan is also to evaluate intubation through the device with a standard endotracheal tube and with a standard intubation technique, just seeing what's going on, how good we can get it, the episode of desaturation through the procedure, the quality of view during intubation attempts. So this is coming soon. Meantime, I've been using the mask for different purposes. This is a really short video, but you can see two screens here because we are performing a percutaneous tracheostomy, and we're using either a bronchoscope inside the mask and the possibility from the mask to take a look at what's happening, driving also processes through the larynx. I don't think we can use this device as a substitution for the bronchoscope for tracheostomy, but the combination of the two may be useful because ICU patients have laryngeal damage in a higher degree than our patients. So knowing exactly where you are, adjusting the maneuver can be extremely useful. So I'm just going to about to finish my lecture with an important point. What we know today is that it's definitely time to abandon the vintage laryngeal mask highway. So the first generation is gone. It's probably too early to speak about third generation because we don't have a specific feature which makes the difference between third and second, just like the gastric access did between second and first. But what we know today is that supraglottic airway devices are available and safe alternative to intubation. If you have to use them, you can only use second generation devices, which means gastric access, and that probably a second generation intubatable device with incorporated vision may represent the next step in supraglottic airway device evolution. Because we started speaking about evolution, and the reason for this evolution could be interesting. This was pretty human. At a certain point, Richard Gere was explaining Julia Roberts about melodrama. And he used to say that melodrama is like this, either you hate it, either you love it. probably the users of supraglottic device obey to the same rules. So you will have people who are enthusiastic about supraglottic and may use them for everything. People who will be reluctant because they are so emotionally linked to endotracheal intubation. But what is sure is that these devices have been using more and more. The reason behind this, many, I like to underline this one. There's an important amount of literature telling us that if we are using a supraglottic device in place of a tube, we can be more gentle on the larynx. We can have better results after surgery. Laryngeal resistance after surgery is minor, is reduced if you use a laryngeal mask. You can have better reflexes. You can maintain the bronchial mucus transport through the procedure if you use a supraglottic device and not a tube. You can spare the larynx in terms of trauma, but also in terms of medication use, which can have some effect in terms of postoperative discharge and turnover on the surgical bed. So many reasons to consider this device as a first into airway management device. And while we'll be waiting for the 27th generation supraglottic device, which will maybe provide also espresso, which is a drama for an Italian like me when I travel around the world. Well, waiting for that time, probably we should listen to Elon Musk when he says that you shouldn't do things differently just because they are different, because they need to be better. And so with these devices, we probably have an interesting opportunity to make some things better. And in the end, as Charles Darwin said, it's neither the strongest species who survive nor the most clever, but the promptest to changes. So I invite you all to be prompt to these changes, to test them on your own, and maybe to get something better in our daily practice. I thank you for your attention. It was really a pleasure to be here. And if you have the opportunity, take your time to consider joining us in Istanbul for the European Airway Conference in 2024, next year in Florence for WAM, and take a couple of minutes to perform this survey about awake tracheal intubation. Thank you so much for your attention and happy to answer to any question.